Bandhu sir is here.
Bandujeewa, can you hear me? Bandujeewa, can you hear me?
Can you hear me now?
Yes, I can hear you.
Yeah.
All right. Thank you very much, Bandujeewa, for joining with us. And Ajit will also join soon. So today, what we are planning to do is discuss some possible orthopedic short cases or most favorable orthopedic short cases which students may get in their exam. So we mainly concentrated on limb fractures, plaster cast, and external fixators, and little bit about fracture neck of femur as well. So I hope you and Ajit will take over from here, and you may ask questions from a student whom you can sort of select from the participants. Okay.
Yes. So yeah.
Okay, sir. Then I'll move on to the first
You can
one.
pick up someone, no?
Yes.
So I think I selected we selected some fellows from
Yeah,
the current
exactly.
group.
So why don't they can answer, no?
Students,
Yes.
Students, who is the one who is going to do the first Viva? Ishani, who is going to present the first Viva? All right. Asara.
Yes, sir.
Okay. You are ready now? It's a sort of a very informal thing, though, so don't worry. So don't panic. So you can see these X-rays. Can you see these pictures and X-rays?
Yes, sir.
Yeah. So can you describe this? There are two X-rays, no?
Yes.
Can you see that?
Yes, sir. In the X-ray A.
Yeah, X-ray and yeah.
It's the lateral view of the forearm,
Yes.
including the wrist joint and the
Yes.
distal forearm bones, radius and the ulna, and including the metatarsal bones and the carpal bones.
Okay.
The B, X-ray B is an anteroposterior view of the wrist joint, including the distal ulna and the radius, and carpal bones and the metatarsal bones, including the distal proximal phalanxes.
Exactly. Your description about the X-ray is very exact. But the area that we show, yeah. What do you see? What do you see there?
So there's in the X-ray there's a distal radial fracture with distal displacement.
Yes.
And in the X-ray B, it's a transverse fracture.
Okay.
In the metaphyseal area.
Okay. You are quite right. When you are describing a fracture, so you have to describe which bone it is involving, and then the area of the bone, quite right, and then the direction, whether it's transverse, whether it's sort of a oblique. So you can. Oh, you are quite right. Okay. Then. So it's a fracture that you see at the distal end of the radius in the metaphyseal area, which is actually transverse with some. There are small pieces also, no bit of a combination, but yeah, with displacement. So how will you describe this displacement as you see here?
In the distal distal radius, there's a dorsal displacement of the distal fragment with distal tilt.
Yeah, you mainly see a distal, actually, distal part is angulated dorsal, rather than
Yes.
displacement. There is some displacement, but mainly angulation. You can have displacement, you can have angulation.
Yes.
So dorsal angulation, what is do you see if you see the anteroposterior view?
It's deviated to the radial side.
You are right, mild deviation to the radial side. This is there's not deviated very much, but there's a radial deviation also. So there's a dorsal angulation, radial deviation. Yes.
So the fracture is most it's a Colles fracture.
Yeah, it's called Colles fracture by its name, but your description is the one which matters. But it's called Colles fracture, and it is very, very common fracture. So you have dorsal angulation, you have a lateral displacement or radial displacement, and also there's some degree of shortening as a result of. Can you see on the dorsal side? There's a overlap between the proximal and distal fragments. That means the distal fragment is driven into the proximal fragment. No, therefore there's some shortening also. So three basic features, that is shortening, dorsal angulation, and lateral deviation. So this is called Colles fracture. One of the commonest fracture. How do you get this fracture?
This is most commonly occur when a person falls on the outstretched hand with the forearm in a pronated position,
Yes.
and the wrist is in dorsiflexed.
Yeah, and the wrist is also, that's how we protect ourselves when we fall. So that's the exposure. So when you keep your hand, the body weight falls on this area, and very good. So description is very good. So what this is relatively minimal displaced fracture, but actual fractures that we see can be very much more displaced. So what are the complications that you can see in a fracture like this commonly, especially if there's bad displacement?
Yes. With so there's a minimal displacement here. If there's
I'm asking, if this is badly displaced, what complications can they get?
There are early complications like damage to the neurovascular bundles, like here most commonly involved nerve could be radial nerve, and
What is a radial nerve?
If the dorsal segment is as the dorsal segment is displaced dorsally,
what part of the radial nerve is left by this time? By the time it reaches this, what part of the radial nerve is left? Main part of the radial nerve is not there. No, actually the posterior this is already, it's finished, and only superficial branch is there. No.
Yes.
So there's hardly a radial nerve by the time it reaches this area. No. Only superficial branch is left. No, the other branch supplies the posterior. This is that supply the muscles and finish. No. Don't you think so?
Yes, sir.
So hardly any. I mean, just a superficial branch is left that can escape, that can slip to any direction and escape. No. So what are the two big nerves that are remaining active or supplying the structures in this area?
Median nerve and
median nerve in front, in the middle, and ulnar nerve on there. No? So yeah, so not radial, right? So see the direction of the angulation of this. So what gets stretched?
Median nerve is,
yeah, that's right in the middle. No, if you see the ulnar nerve, that is on the ulnar side. No, that will escape because the ulnar bone is not fractured. No.
Yes.
So it's the radius that is fractured, and then this dorsal angulation will definitely stretch the median nerve. No. Okay.
Yes.
So how do you recognize the median nerve injury in this patient?
There can be symptoms like acute compression to the median nerve, like sensation loss in the thenar eminence, and and the loss of movements of the muscles of the thin eminence, like
Actually, if you ask about any nerve injury, you have to talk about only motor and sensory, no? So you have to know the exact area supplied by this median nerve in this area, no? Beyond this area. So what is the area supplied by the median nerve beyond this area? Not near thin eminence.
the median.
For example, in the case of carpal tunnel, what is the area that people feel numb? You commonly ask that question from patients.
The median to 1/3. Sorry, the median 1/3 of the fingers, palm aspect of the fingers.
Not accurate. Medial 3.5 fingers. So that's what we say on the palm side. That is a standard area. That's what is anatomy. So you get numbness. Motor function very difficult to assess. In this acute situation, very difficult to assess because mainly the thin and the lateral these things umbilicals are in danger. So but their function cannot be elicited that easily. So mainly you got to go by sensory. So what else? Yes, if say there's a major displacement. So neurologically you assess that. Of course you can assess ulnar nerve also. Fine.
The damage to the blood vessels.
Yeah. How do you assess that?
I could check the radial pulse and the capillary refill time.
Now, if you think sensibly, now this is the area where there's fracture, no? Radial arteries going just over that, no?
Yes.
And if this badly, I'm asking if this badly spaced, so it will be swollen there, no? The whole area will be swollen, right? So in that you can feel pulsation in a swollen, deformed wrist. If you can, that is well and good, but it's almost impossible, no? If it's badly spaced. So how do you then assess further distally?
The capillary refill.
Say for the whole area swollen, you can't feel radial pulse. Yeah, I mean capillary refilling time. That's how you do generally, right? So there's in the exam you have to know properly these areas, how you check, how you assess the injury to median nerve, ulnar nerve, radial nerve. You have to know. And and also how you assess the distal circulation, that you have to know very accurately because those are basic things. Okay, so this is a collar fracture. So the patient comes to you. So if you are the house officer and there is no PCU, if you are to the primary care, so how will you set about preparing this patient for further management? What is generally done with your knowledge? What is generally done? What is the management in this patient? Definitive management is what generally?
Definitive management is close reduction under anesthesia.
Close reduction under anesthesia. Very good. Yes, and application of
plaster cast
very
for the immobilization.
Sorry?
For the immobilization of
Yes,
the
for the
joint.
purpose of immobilization, put a plaster cast. So how to prepare? Say this is a 75-year-old female presenting to you with this fracture. How do you prepare?
First, I would take a brief history regarding the mechanism of the injury, and I would ask for any medications, whether she's taking like anticoagulants or antiplatelets, and ask for any allergies.
Okay, those are the basic steps you take now. So assume that you have done all that. How do you straight away prepare this patient? You have taken a detailed history, you have done other general examination, excluding any other injuries, and these only problem. Otherwise, she's fit. What kind of anesthesia can we use for this patient? What is the type of anesthesia that we use, or what types of anesthesia is available for this actually? What are types that are available?
General anesthesia
Yes,
and
one thing. And
local anesthesia.
what do you call that local anesthesia? What form?
Mm,
Do you know any special name that is given to the local anesthesia that we use here? If it is done under, especially if it's a patient like this with a minimum displacement, if the patient is very elderly, there's a thing called, if the patient presents acutely like a hematoma block. Have you heard of that? Hematoma block.
no, sir.
That is very frequently done, especially in the West. It's done. It's an sort of outpatient procedure. It's a day you can be done. You inject lignocaine and wait a little while. That's a special technique that we use. You into the hematoma and make the area numb, and then you do the manipulation. But of course, you can't get a perfect. Sometimes it's difficult to get perfect reduction. But in a case like this, what you see there, which is minimal displacement, that's a good option. So that you have to know hematoma block, which is one form. So that is one form of anesthesia. The other one you have already mentioned. If it's badly displaced, you can't use a hematoma block and get a good reduction. What's the other form of anesthesia?
General anesthesia.
Okay, if the patient is not suitable for general anesthesia, and if the local anesthesia, hematoma block is not sufficient, what are the other options we have?
Spinal anesthesia.
Spinal? At what level are you going to give the injection? Which spine are you going to?
No, so nerve block.
Yeah, nerve blocks, very good. There are various forms of nerve blocks. This thing called BS block, which you have read. There are various. So having given anesthesia, how do you manipulate this patient?
First there's counter traction force
Traction and counter traction. So somebody will hold by the elbow, the other person will pull by holding at the hand. So you can traction and counter traction, and also you know the deformities. You move in the opposite direction. So you know it's a dorsally angulated. So you pull and put it down in the ventral direction. And you know it was radial deviated. So you turn towards the ulnar side. And now you can see this plaster. If you turn to a plaster, the patient's hand is, fracture was dorsally angulated. So that this has a wall angulation. Right?
Yes.
So you move the fracture in the opposite direction. And by pull, you reduce the, correct the shortening. Pull will correct the shortening. This wall angulation will correct the dorsal angulation. Ulnar deviation will correct the radial displacement. So in this view, you can't see properly, but if you take the X-ray picture from the top, you will see all that. So as you see, this is a half cast that is applied. Sometimes you apply full cast to half. So this is a very important thing, very frequently asking the questions. So this all done. So you are the house officer. This patient has gone to the theater and has already had this plaster cast. And how do you look after this patient for the next, say, 12 hours or 24 hours that before discharge?
I would examine any signs of compartment syndrome, like the passive pain while moving the fingers passively, and the capillary refill time. And I would keep the.
Okay, you are quite right. You have to look for them, but before that, to avoid such situation, don't you think that we have to give certain instructions to the patient while in the ward? I
would ask the patient to elevate the limb, and
that is the most important thing. As soon as patient arrives, you must keep them in a few pillows, or you can use the reverse arm sling to keep the hand elevated almost to 90 degrees. Fingers up, elbow down. That is mandatory. Then only you will avoid. So that is something that you need to mention in the exam, as well as you should see in the ward whether the patient's arms are elevated when you are working as a house officer. Okay. So that is that elevation. What other instruction will you give?
I would ask the patient to move the fingers.
Quite correct. Move the fingers. Why do you ask the patient to move the fingers?
Otherwise, there could be complications like joint stiffness.
Very good. Long-term complications. So you start rehabilitation immediately. You get the patient to move. Move completely. Thumb, fingers. And also they should move elbow. And also the shoulder. Otherwise, all that these joints can become stiff. And now further, what's the other advantage of movement? By moving the fingers. Blood circulation will improve, no?
It could help in reduce the swelling.
Exactly. It will take the fluid away when the circulation. So those two are very important, right? So, and then once you give those instructions, then what do you look? Then you have to monitor. So what do you monitor?
So I would monitor for the signs of compartment syndrome.
Those are actually the last thing that you will see. The compartment syndrome is the last thing that you should, actually something that you should not see. Before that, you have to intervene. So there's no point in seeing signs of compartment syndrome and then coming back. Okay, she doesn't have, this patient doesn't have signs of compartment syndrome, so I'm not bothered. So that is not the way to approach. Because compartment syndrome is, if you see the signs of compartment syndrome, that means you have not monitored the things that you should have monitored before that stage. Did you get what I'm saying?
Yes, sir.
If you are monitoring and if you are going to act when there's a signs of compartment syndrome, that means you have not seen the signs that you should have seen before that. So what are things that you must see before that? Signs or symptoms?
I would ask daily.
These are called not signs of compartment syndrome. These are called signs of tight plaster cast, right? So you must catch that at that stage, tight plaster cast. By the time patient develops compartment syndrome, that means your cast has been too tight and the swelling has increased so much, or both have happened and caused a compartment. That's a major area. You don't have to wait till then. So you must watch for whether the patient develops features of tight cast. Last stage of that is compartment syndrome. Did you get?
Yes, sir.
So you have to look for signs of whether they are tight cast. So what are those signs? We are going to mention the last of them. But before that, what are things?
The pain.
One thing is pain. Yes. You will have pain which cannot be controlled with your normal medications. So if there's severe pain, there's no point in pumping a lot of things, right? You must act before, right? So there are other things that you need to do. So what are things? Okay, one is pain. Symptom is pain. That is excruciating, or pain that is not the disproportionate to the problem. Okay. Then
the capillary refill time.
That again is pretty late sign. No, if the capillary refill time is if it is longer than it should be, that means a problem. No, there's no point. Those are late features. No, that means circulation has been impeded already. What is the other common thing that you are discussing? What do you look for?
Numbness of the fingers.
That may be little early than what you were telling before. No, the swelling of the fingers. No, first thing will the swelling. That is what we look for in the morning or whatever time. If you notice the previous swelling and the swelling is increasing, that means the patient is developing This is the first thing that will happen, no, because the first thing will be the venous circulation will be blocked. So then you get, because of that, you get swelling. But if the patient is getting a lot of swelling, either developing progressive increase in swelling and the excessive pain, then that's the time to act and do what is necessary. The things that you describe as, the pain, severe pain during, passive stretching, active movements are not possible, and then the capillary is slow, patient develop numbness, or very late signs. Numbness is little earlier than others, but those are very late signs. Those are signs of compartment syndrome, right? So if you have to do that, we are very late. So by that time, the swelling, the fingers will be fully swollen, right? So the early things are excessive pain and the swelling of the fingers. And then, of course, you can touch and just see the patient with a passive movement. The active movement is not possible. That means active movement may not be possible because of the injury per se. Especially in a situation like this, very difficult to elicit active and passive stretching and this, because the injury per se may cause a lot of pain during movements. So that way of assessing may be very difficult. Okay, so those are the instructions that you give. So they're not the instructions that you monitor. Then what instructions will you give on discharge to this patient? Those are very important.
I would instruct the patient on moving the shoulder, elbow, and the wrist, the free fingers.
Fingers, all fingers. Okay. So very correct. You have to ask them to continue what we have been doing here at home also. Second thing?
I would...
you ask the patient to keep the hand elevated at home also, because otherwise the same thing will happen, no? Then third thing, and the other thing, you have to tell them, otherwise they would not do. You must tell the things that you are monitoring here. If you are developing any swelling, or if your pain is becoming worse, or if you're dealing any pins and needles, those signs, come to the hospital immediately. So unless you give these instructions, they will not do. They will wait for the next clinic visit. By that time, you are too late. So those instructions are important, right? So I think we have taken a lot of time to describe this collar structure as well as the cast. So I think we have covered mostly the the things that you need to know related to POP cast and these things. So we can move to the next one.
Yes, sir.
Yeah.
Ajit sir, do you have anything to add?
Yeah, Ajit sir is there. Yeah.
He's here. Ajit sir.
Ajit?
Discuss in detail. That's fine.
Okay, sir.
Ajit, now once we put the plaster cast, do we always have to take an X-ray to confirm the reduction?
That's the area I did not discuss.
Yes, unless it's done under image intensifier, it's important to see whether it's corrected or not. So we have to do a post-reduction X-ray.
Right. So students, it's two things very important. Dr. Bandujeewa emphasized that we should look for impending features of compartment syndrome, not the established compartment syndrome. Most of your notes, the old notes which you are carrying, say 6 P's of those are features of established compartment syndrome. It's no point detecting those things because the limb is gone by that time. So you have to be alert. So you have to see the features of tight plaster or impending compartment syndrome features. Another thing, what is the extent of this plaster? Ajit.
This college plaster, it should be done in such a way that the thumb and the other fingers should be able to, we should be able to move it. And here in this plaster, I think it's not done properly.
Thumb is little bit.
Thumb where the metacarpophalangeal joint of the first the thumb should be exposed so that the movement can be done. Here it's basically, I suppose, it's covered here.
Right.
The other thing is normally the distal end of the cast is ending at uh, the proximal palmar crease. So the fingers are free to move in that way. And when you see the proximal end of the cast, that is okay, and it should not impede the elbow movements, and it should not go and hit on the arm so that it can cause some skin problems as well. So apart from these things, but this particular cast is not the ideal. So there are some corrections to be made here.
Okay. When do we put a forearm plaster cast where we cover the thumb as well?
I think we are going to discuss that matter a little later. No? So shall we wait for that, or you want me to go for that?
Yes, sir. We are going to have a Viva on that as well.
That's a separate slide for that. Eh?
Yes, sir.
Slide for that, I suppose.
Is there a slide?
Yes, I think Hasara can comment on this as well, Bandhu sir. Same student.
This sir can take this one, no?
Yes.
Yes.
Hasara, are you there?
Yes, sir. There's a there are two distal radial and ulnar fractures displacing the ulna and the radius to the ulnar side. Hello, sir.
Yes, we can hear you.
We can hear you very well.
There's a dorsal angulation also.
Can you look at very carefully?
It's dorsal.
On a lateral X-ray, how do you identify the anterior and posterior aspects of the X-ray? What is the indication in a lateral X-ray, in this X-ray, wrist X-ray?
So the curvature of the palm with the curvature of the arm.
Why don't you look at the thumb here? So when you keep the hand lateral view, so normally thumb is anterior to the other four fingers, correct? So if you can identify the thumb separately, that is the anterior. You understand what I'm saying? Look at the lateral view of this X-ray. So you can identify the thumb because all the other four fingers are in one line, and one finger is anterior to those four ones. So that is the anterior one. So you understand what I'm saying?
Yes.
Pinto, can you indicate thumb with the cursor? Yes.
This is the thumb.
Right. That is the thumb.
This is the thumb. And these four are in one line. So it has gone this way.
So did you understand? Thumb is anterior.
Yes, sir.
Right. So the displacement is anterior. Not like the collar's fracture which you described earlier.
Yes.
Okay, keep on describing. Did you say that the fragments have deviated to the ulnar side or not? What did you say?
Yes, sir.
So ulnar
No,
is
sir. The fragments are deviated to the radial side with distal fragments with the ventral tilt.
Okay, fine. So it has deviated to the lateral side or to the radial side and to the anterior side. Okay, tell some.
This is the Smith fracture.
Okay. So you can describe some more. So the fragments are shortened. You see there are some overlapping there, and
The,
there are indications of some comminutions also. If you want, you can
the,
describe them. Hmm?
there are both the ulna and radius. There are two transverse fractures, complete transverse fractures, and the bone fragments are impacted on each other. Um,
Anyway, now I think most of these other, the complications and swelling and all those things have been discussed earlier. So tell me now, according to this, anatomy. So there's a abnormality in anatomy. There's a disruption in anatomy. So if you want to correct this one, what are the things? What are the maneuvers you do in reduction?
in reduction, sir, traction and contraction to reduce the impaction of the two.
Yeah, that's good. Good. Initially, you do that. Yes, traction and contraction, and then
Uh, as the fragments are radially deviated.
that's
Uh,
fine. Okay, accept it. Now, after that, what are you going to do? So, traction and contraction to get the length properly. Okay.
yes.
First, you do the traction of with contraction so that you can achieve the length. So, it is shortened now. So, then what are you going to do?
Then the distal fragments are replaced in ulnar deviated and dorsiflex position.
Yeah. Okay. You now it has gone to anterior, so you push it posterior, correct?
Posteriorly.
Yeah, once posterior, and also it has gone to the lateral side, so you push it
Medially.
medially. Okay. So those are the maneuvers you do in the reduction process. So once you achieve the reduction, satisfactory reduction clinically, then what would you do?
Then I would apply the plaster cast uh, from the above elbow, uh, extending to the metatarsals
Why do you go
for
for
the
above elbow?
immobilization,
Why do you go for above elbow?
so that we can immobilize the elbow joint to give a proper immobilization to the wrist joint, uh, and it by that the rotational deformities can be prevented.
Dr. Bandujeewa, would you agree with that? Or?
Yeah, that's okay, because so in Smith's fractures, you are advised to put a bow elbow cast, bow elbow cast, unlike in a collar's fracture. Collar's fracture is the only place where you sort of, because fundamental thing about cast application for a fracture, you have to immobilize the joint above the fracture and joint below the fracture, immediately above, immediately below. But you must remember the application of POP cast in the case of collar's fracture is an exception. So in the Smith's fracture, which is not the, generally this occurs in relatively young patients, people, rather than the like we can call a fracture. So you are advised to apply a POP cast above elbow, and next to the distal end is, as quite rightly mentioned, should end at the distal palmar crease, exposing all the metacarphalangeal joints. So, and also it's applied in basically supination.
Okay, now can we see the post reduction with the plaster?
Sorry, sir. For the Smith's
We
fracture, I
don't
have
have.
not included the reduced the POP cast. I
And
haven't.
yeah, other thing, don't mistake, because there is a associated ulnar fracture here, right? Now in a typical Smith's fracture, you don't have that, right? Typical fracture is a Smith's fracture is a distal radial fracture, but here there's there's additional ulnar fracture also. So whether we can exactly call this Smith's is another issue, but this quite rightly fits into the the typical position of the the displacement sign, the direction as in a case of skis fracture.
Yeah, yeah, as you said, it's correct. In good olden days, we normally, call them Smith structure, college structure. Nowadays, that's
Yeah,
hardly used.
yeah,
You normally, because distal radius structure, you describe the structure so that you can accurately describe what it is rather than, giving it a name so
yeah.
that, you don't get confused with this.
Shall we
Yeah,
move on to the next one?
basically that's enough. I mean, there are complications, and I think earlier in college structures also you all described the complications also. We don't want to repeat it, so we'll move on to the other one.
One thing to mention before this leaving to the next one, there's a thing called, now we have already heard two names, Hollis and Smith. There's a thing called Barton's. Just remember the name. When the fracture goes into the wrist joint, it's called intra-articular fracture. And when there's in this, you can't see any intra-articular extension. There's a different name. That's called Barton's fracture. Just to have heard this name. That's all. I think you can move to the next one.
Who's joining us for this Viva?
I am, sir.
Okay.
Okay. Now, okay, describe the X-ray.
There are two X-rays. The first one is a lateral X-ray of the forearm extending from the elbow joint to the up to the metacarpal bones, and there is a distal ulnar fracture, possibly in the junction between the middle 1/3 and the distal 1/3 of the ulnar bone. It is mildly displaced, and it is displaced towards the
Yes.
Towards the posterior side.
It is displaced towards the posterior side. Now you are looking at the first X-ray, no?
Yes.
Okay. So which is posterior? Which is which is posterior? Now tell me. That has two fragments. In other words, yes.
Proximal part is proximal part is posteriorly displaced, while the distal part is anteriorly displaced. There is mild overlap between the bone parts, and there can be a bone forearm shortening.
You quite rightly told. Now corrected yourself now, right? Because now when you are saying anterior posterior, you have to refer to the fragment. Otherwise, because you are telling posterior, but I am seeing that distal fragment is anterior. So when you are trying to describe the displacement, always relate that to the fragment, right?
Yes.
Okay.
Now, Bandujeewa, the common consensus is sort of when we are describing a fracture, we describe the displacement of the distal fragment, isn't it?
That's it.
In relation to the proximal fragment.
Generally, more so in dislocations.
Yeah.
More so in dislocations, here you can, but if you correctly describe the, proximal part is posterior and the distal part is anterior, that is of course quite acceptable. But generally in dislocations, you are quite right. We dislocate the portion of the distal fragment. Okay, go ahead. Lateral you have described.
The anteroposterior X-ray, the same fracture in the ulnar bone, and it's displaced. It is the X-ray of the left arm. The ulnar bone is displaced. The distal fragment of the ulnar bone is displaced towards the ulnar side. Again, there is a mild
distal fragment ulnar side. Which way has it moved? Towards radius or distal fragment?
Distal fragment moves.
Can you show me, Dr. Pinto? Can you show the distal fragment? Yeah.
It to more
Which
towards
side has it moved?
radius.
Why did you say then the this thing?
I got that. Yeah.
Did you confuse yourself with the distal and proximal? Is it?
And
now when you are describing, I'm just advising, when you are describing these two X-rays, I would have advised you to do this way, because rather than trying to describe the first X-ray, then starting the redescribe the X-ray, because both show the same areas. No, so you can say these two X-rays show anteroposterior and lateral views of the forearm, including elbow and wrist, and the then that describe the X-ray, no, straight away. Because otherwise, you have to repeat that when you describe the second X-ray also. So just after mentioning, these two X-rays show the anteroposterior and the lateral views of the forearm, elbow, wrist, and the proximal arm. That way, describe your X-ray first. Now you describe the fracture. Now lateral X-ray shows the anterior displacement of the distal fragment, whereas the anteroposterior view shows medial displacement of the distal fragment. So there's a distal fragment. Okay, so and how best do you describe fracture? You should be able to describe quickly, not wasting time. The displaced fracture, you have described the displacement and it's more or less transverse with a small spike.
It is an isolated ulnar shaft fracture, which is mildly displaced.
Isolated word, isolated.
There doesn't seem any other fractures or any dislocation of the joints.
No, very good actually. That excluded you nicely excluded radial fracture, which is a common thing. So it's isolated radial ulnar fracture. Okay, very good. Okay. Now, when you see a fracture like this, of course, we previously described what to look for, right? We have already discussed in the yes. So, how do you manage this fracture? I'm not asking seriously. There's a displacement. You try and reduce it. That is a standard thing, right? We are not going to ask whether this is reduction or not. This is another technical matter. But okay, so you manage. So you do a manipulation. Let's assume. So what's the type of cast that you are going to apply here for a fracture like this?
A cast extending from the above the elbow joint up to the first palmar crease, sparing the thumb. A plaster cast extending from the above from the elbow up to the
yes, because above elbow and
above up to the first palmar crease, sparing the thumb.
Distal palmar crease, right?
Yeah, distal palmar.
You have to see should be able to see the knuckles dorsally as well as the distal palmar crease on the ventral side. Two things you need to see, and also you must exclude you should see this joint, the thumb. So now that is very important. So that is the principle is that. So if there's a fracture, you to immobilize fracture the joint above one, joint immediately above one, joint immediately below. Therefore, we are immobilizing the wrist as well as the elbow, right? So, can you describe? So can you describe this plaster cast again that you see here?
The plaster cast is applied on the left arm, extending above from the elbow, extending up to the distal end of the metatarsals, the thumb spared.
I will include the head, then that is wrong.
It looks like.
So this is called typical above elbow cast. That's what I want to say. This is called above elbow cast, full cast. Because sometimes we put only one side. That is called either front slab or back slab. So this is called full cast. This is called above elbow full cast. So when somebody asks above elbow full cast from where to where it extends, you should be able to answer, right? Upper.
Yes.
So we have already discussed the advice that you need, the things that you should monitor in the ward, as well as the advice that you should give the patient on discharge. Suppose this patient, while staying in the ward, she develops severe pain, say a few hours after, and you notice the swelling is increasing and the patient is howling. Of course, the circulation, when you assess, it is very satisfactory. But swelling is increasing, patient is shouting in pain. What will you do as a house officer?
I will check whether the cast is too tight for the patient
How do you check that?
by trying to insert the finger, and if it
Do you think that we leave such a big space between the skin and the cast? If you leave such a big space between the finger and the skin and the cast, then of course the next day the fracture position will change. And you can't leave such a big space so that you can put a finger around the between the cast and such casts are called loose cast, and they are not acceptable. You have to immediately reapply a new cast. There's no such a big gap, right? It is very closely applied to the skin, right?
Yes.
So there's no way that you can put. So how do you know there is a patient? That shows that you have not come to the ward and done any work. Huh? Anyway, how do you assess the tight cast then? Now you're telling you are going to assess tight cast.
There will be obvious swelling in the two ends. Swelling of the there will be swelling in the two ends.
What are two ends?
Above the elbow and in the fingers.
Why should you get swelling above elbow when you are cast? Describe the way it happens. You can have when the venous return is impeded, you can have swelling only the distal end. Of course, the proximal end will be short of blood because your blood has all pooled. So you can remember, I have already, now there's nothing for you to assess swelling, the tight cast. The things that you should assess, I have already mentioned. One is pain, other one is swelling. I told this patient is having both of them now.
Good.
Those are the ways. Then you can assess capillary film. I told this is all normal. Or you can, the next that is left is at the assessment of active and passive movement of your fingers, and you can ask for numbness and things. So those are things that you ask, right? Don't try to put the finger and this. So assessment is done on these signs and symptoms. Early signs are the pain and the swelling. The other things are late, and patient may be dealing slight numbness earlier. So now I already mentioned, right? So what is your diagnosis in this patient? I told his swelling is increasing, patient is severe in pain. So what's your diagnosis?
Tight cast, impending.
Tight cast, right? It's not impending the compartment syndrome, no. To get impending, you must have a capillary, a lot of other symptoms. So I am telling only these two. So it's tight cast. What do you do then?
Release the remove the cast and
So that's not good enough, no? So remember, now you learn, I hope also at least some of you are listening. Now the treatment for a tight cast is okay. So somebody is saying, very good, bivalve the cast. Very good. Can you say how you bivalve the cast? Very good. That's a good answer. You bivalve the cast, right? Can you describe how you bivalve the cast now? Somebody has already answered, right? I saw the answer, right? So how do you bivalve the cast? What are things that you should do? Have you heard of thing called bivalving?
Yes, sir.
Yeah, tell me how you do. So this is a situation where you do, right? Increase in swelling, increase in pain. How do you bivalve this cast?
The cast is cut into two halves. And
cut the, have you seen the instrument that they use to cut the cast? Either you can use there's a hard scissor. You should see these things, or there's a motorized device, right? You can straight away. So how do you know that okay, the attendant or someone is helping you to do the cast? They will come and cast, of course. They are good at it. How do you know whether they have done the job right? It's your duty to ensure that job is done right. And these are things that you will be asked in the question, questions asked in the exam, right? How do you? So remember now, it seems that you don't know this. You have to cut this cast from proximal end to the distal end all the way. Remember, and once you cut, you should see the skin. Now you know under this plaster of Paris, you have some cotton. Make sure you cut that cotton layer also. That otherwise you must think only the tight parts is the POP. No, because once the cotton gets soaked with this POP, plaster of Paris material, that also becomes very hard. So you need to cut it until you see the skin all the way from top end to the bottom end. Remember, and then you can use. There are certain things that you can use either the same there's a standard things use a spreader and move them apart so that you will have some gap between them. There are two curtains. You can do on one side or you can do on both sides and raise, and then you move them, do these two pieces apart, so there will be a gap, and then you get the patient to elevate, re-elevate. You can apply this once you cut it. Of course, you may have to put a the cotton bandage or something around that to make sure that they don't fall apart, and then you keep elevating, right? Because just because you cut, you don't leave it aside, because you have to continue your measures and finger movements. So this little thing you must know, and you must mention the exam, right? It's something actually more than the exam. You must know. These have you save limb. Otherwise, if you discharge this patient like this, giving painkillers, you will be in deep trouble, and then you will get the compartment syndrome, what you call tight cast, and then the. Okay, I think this is what we have to teach about this. No, I think we are done. We are done with this, Dr. Pinto.
Shall I ask one question?
Yeah.
But the previous one. Just 1 minute. From the students, would you, just a bit of an advanced question, would you accept this the fracture management in this patient as it is with a plaster? Will it give a better result? Anybody?
Yes, sir, because the displacement is less than about 50%.
50% contact is there, I accept it, but I'm asking whether would you accept this as a final reduction? Probably this is the final reduction here on the left side, and will you accept it with a plaster? Anyway, I would say I would not. You know why? Otherwise it will take time. I don't see this is a child because epiphysis is not seen here. So I feel like it's the epiphysis have fused is an adult, so that there's not much chance of remodeling, and this contact surface will allow it to heal. There's no problem with the healing. I suppose it might heal. Only thing is pronation and supination will be affected because there's no proper correction of the rotational movement. So I think this is a good pictures for to understand the plaster cast application, the way of it is done, and the complication of it. But finally, management wise, this one I feel like it should go for fixation. Any other views? I would like to.
Yeah, this is definitely case for internal fixation. Yeah. I don't think this is satisfying. This is only just to teach this. Otherwise, this is not a, in a child, of course, you would have thought this needs fixation. No?
I just told him the other
way. Yeah. Good. Okay, otherwise, they will think that this is to be managed.
The way of management.
Yeah.
Okay, we can go to the next one.
Hello, sir.
Ajit sir can take it, no? Dr. Pinto, who's the student?
Yeah, the one who just
Hello,
spoke.
sir. I'm Bhagya, sir.
Till what time this session is going on? 10:20 or?
Pinto, aren't we got any male students?
These are the ones they have chosen, sir.
Okay.
How many more minutes we have got to go on?
It's
We have
all
to have
right.
another session, I think.
It's okay, Ajit. We'll finish this today and go to the lower limb next week.
We can finish all this.
Sorry?
Can
we
we
have
finish all this?
we have only these ones for the upper limb. Then
Only you?
yes.
Right. Okay, fine. Okay, somebody can describe this problem.
Hello, sir.
Yeah.
This is a X-ray which showing the wrist joint, including the metacarpus, carpal bones, and the distal ends of radial and ulnar.
Yeah. So, yeah, go on.
There is a transverse fracture in the scaphoid bone at the distal pole.
Yep. Okay. Would you want to see some more pictures of X-rays or this is okay?
Uh, uh, if the lateral view is given,
Yeah, there are special views called scaphoid views. Anyway, this one
yes,
is good enough
this is
by the fracture. It's okay. Okay, how normally what is the history of this patient? How do they
history will, yes, sir, history will be fallen on an outstretched hand with the hyperextended and radially deviated wrists.
Yes. Okay. And then patient comes with a pain and tenderness and
Pain,
swelling. So
pain and ten,
how do you
pain and
identify this? How do you suspect?
patient presents with pain and swelling in the anatomical snuff box.
And how do you
And
normally pain and swelling around that area? You don't know whether it's anatomical snuff box or any other area because it's a diffuse swelling. How do you examine and identify?
uh, pain can be induced through axial compression along the first metacarpus,
And also you can press on the
uh, anatomical snuff box.
okay, right. After that, you now we are going on the reverse way. Normally, we should go with the presentation and with the X-ray next. Anyway, now just because we put the X-ray on and then we are going reverse. Anyway, uh, so patient presented with like that, and you diagnose it, and then you go for X-rays. Now this is the X-ray.
Yes.
Now, what is the particular concern about this fracture? So it's a scaphoid fracture. Okay. So what is the concern here?
Yes, this is distal end fracture of the scaphoid bone. Uh, uh, the the if here the scaphoid bone gets the blood supply from the distal end in a retrograde manner to the proximal end, and if the distal end is fractured, it is less likely to get complications. But if the proximal end is get fractured, it is more likely to get avascular necrosis.
Okay. So, what are the other bones in the body you get avascular necrosis?
Uh, femur, talus, femoral head, talus,
And
and neck of the femur, humeral heads.
humeral head is not a. What is the particular characteristic of these avascular necrotic ones? They have what kind of arteries?
Uh, End arteries.
And arteries. So, what are the other bones? One is scaphoid. You said the head of the femur. Then you said the talus, and what else?
Femoral heads.
Then
Femoral head and head of the femur same, no?
yeah. Anyway, I will tell you. Lunate is also considered as a endarterectomy. So anyway, now
And you mentioned the humeral head. That is not a common thing, right? Remember, humeral head is not just because the humeral head is undergoes avascular necrosis,
Okay, sir.
but a common thing, unless in extreme.
so now what is the line of management in this case? Initially, what would you do? So you after assessing the patient, giving painkillers, and also then what would you do?
Uh, this is a fracture in the distal end, sir. Therefore, we have to detect with via the radiological imaging, and then if the fracture is non-displaced, we have to put a distal short-term thumb spica cast, sir.
What do you call it? Scaphoid plaster, correct?
Yeah.
What is the normal method of putting the scaphoid plaster? Suppose if you are a house officer and the patient is presented in the emergency you saw, and uh, you are given the chance to put the plaster on. What is the method you are employing in this case?
So I didn't understand the questions.
How do you put the plaster on? What is the mechanism? I'm asking now. The college fracture plaster is also something like this, no?
Yeah.
Something like this. So what is the difference here?
We put the plaster including the thumbs.
So how do you do that? We ask the patient to keep the hand in what position? It's called glass holding position. Have you heard about it? And
No.
thumb means you have to cover the metacarpophalangeal joints and the interphalangeal joint also. Okay. Bandujeewa, anything you want to ask?
The most important thing about this scaphoid fracture is that is a fracture that most of us miss. So if somebody presents you with the pain in the wrist, right, and swelling and pain in the wrist after fall, say if your initial X-rays do not show any fractures, and if you suspect, and if you have the anatomical tenderness in the anatomical snuff box area, and when you telescopic tenderness, if you have the suspicion, that alone is enough for us to put a cast. There are ways. Generally, then what we do is we repeat the X-ray in 10 to 14 days time, and to see whether you will see an undisplaced fracture. So, the teaching is, if you suspect a scaphoid fracture, then you need to apply a cast. The way to evaluate is, of course, before you put, you can do a scaphoid views, special views. If even they don't show it properly, unless you can go for a CT scan, you have to put a plaster cast, and then review the depending on degree of suspicion. If you have very high degree of suspicion, you can go for a CT scan or something to confirm. Otherwise, you do the scaphoid views, but then you apply a cast. Even if you don't see it there, then you have to reevaluate with a new set of X-rays at 10 to 14 after about 10 to 14 days. If that is also negative, then of course you can leave alone. But even that is suspicious, then you have to go for further imaging. So otherwise, this is something that we frequently miss. Because sometimes, as you said, this undisplaced fracture here, if you don't treat, now this is minimal displaced. There are even more undisplaced, which are even less displaced. Such fractures will displace over time. By the time they come to you after a few weeks, maybe months with pain, then you detect suddenly a big fracture, which was missed in previous X-rays. So suspicion is enough to put it and you keep for about 2 weeks and then review. You have to understand this as a frequently missed fracture. That is very important. Otherwise, we will be very. So, what are the complications? Why are you worried about this fracture? As you said, it undergoes avascular necrosis. So, why are you worried about avascular necrosis? What are the problems that you get?
It can't reverse, sir.
Yeah, so let it be. So there's again, let it be. What's our problem? That's a theory, no? What is the problem with the patient? What's the problem with the patient? What do you think? The patient will have a permanently painful wrist. And what happens when the AVN occurs? You will develop over time. You will develop osteoarthritis around that carpal bones. So you develop osteoarthritis of the wrist, and he will have a painful wrist. So that is why we have here is avascular necrosis, but you have to know why are you worried about this avascular thing? So it causes painful wrist and predisposes to osteoarthritis of the wrist, and then it's a painful wrist. So that's why we want to take measures to stop this.
Somebody has asked how to identify hairline fracture. I think partly the answer has been given by Dr. Bandujeewa. So if there is a hairline fracture, if you don't identify it, you can do another repeat X-ray in about 10 to 14 days time to see whether there's a sclerotic margin. One way, the other way is you can go for MRI scan later.
Ajit, what do we do usually, the MRI or CT scan?
Sorry, CT scan. If I make a mistake, sorry for that. It's a CT scan.
Ajit, Bandhu, can I just ask a question? Now, we in a patient like this, a youngish patient, you all usually do bilateral X-rays when there are epiphyseal lines?
In what patients?
In young patients, when you see epiphyseal lines,
yes,
you take X-rays in both hands or to compare the two X.
No, that is no, in a situation like this, there's no need of a comparison. No, we can see. So, but not really. That we do in situations where this epiphyseal, the bones are not really visible very early age.
Yeah.
Or if you are worried about this epiphyseal displacement, what we call Saltaris injuries, if you really want to compare. Or when just certain bones are not visible at all, only few epiphyseal centers are seen, then of course you want to see compare with the other side and give a comparison. But not really in a situation like this where all the bones are readily visible. There's hardly anything, because we know there's no definite now across this scaphoid there's a line here. Now generally we know you can't have a line like this in the other side also. This line per se is abnormal. So there's in this case you don't have to compare with the other wrist. But generally in young children, sometimes you have to compare if you're very early. Yeah, in a different situation.
Thank you.
Yeah.
Shall we wind up for today, Rohan? We have to do lower limb also. We'll do it on next Sunday.
Yeah, I think we also learn a lot of things. Thank you, Ajit, and thank you, Bandhu. Most of things are new for us as well.
And Bandujeewa and Ajit, I must thank you again. And we would like to hear from you next week as well. Students, just to recap what we have learned today, it is very important discussion today. And you should know how to describe a fracture. Now, when you are describing a fracture, you have to sort of describe the X-ray, as Dr. Bandujeewa said. Then you have to say whether the fracture is transverse, spiral, and whether it is comminuted or not, and the part of the bone which is involved by the fracture, whether it is the epiphysis, metaphysis, or the diaphysis. And then the most important thing is the describing the displacement, right? So if you are describing the displacement, you have to mention that distal fracture segment is displaced, usually in 3 planes, posterior, anteroposterior, medial lateral, and the short knee or the backward displacement. Then we talked about the initial management of fracture, diagnosis, pain management, then definitive management. So there we emphasized on sort of fracture, disimpact the fracture, then stabilize the fracture. Then sort of one modality we discussed today is sort of using a plaster Paris cast to maintain the reduction. The other modalities will be discussed later. Then we talked about the basic principle of fracture immobilization, except in the Colles fracture, we tend to immobilize one joint distal and one joint proximal. And we were indirectly talked about sort of three important radiological views sort of we have to take in a fracture. We have to take two different views, anteroposterior, lateral, and two joints in one proximal and distal, and in two intervals in especially in a scaphoid fracture where we don't see. And a little bit about avascular necrosis, the common bones in the body which involves the avascular necrosis and the problem of avascular necrosis. Hope you will retain these things, at least about 10% of this thing will help you. And mind you, very important thing emphasized by Dr. Bandujeewa was the post-reduction management of fracture. We have to look for tight plaster, symptoms of tight plaster, and we don't wait until they develop 6 P's. So that is also very important, and the management of a tight plaster. Thank you very much, Bandujeewa and Ajit, and others also.
Just as a just an anecdote to as a general comment. Can you hear me?
Yes, yes.
A lot of students, when they ask questions, they take long time to answer. So I think all of you should in the exam also you're given a limited time, so that they should learn how to assimilate things and put it in words so that we can understand, rather than taking long time. I mean, at this stage, taking long time in learning process is okay, but I think they should learn that also, because that's also part of learning process. What do you think?
Yes, of course, of course. Sometimes students might think taking a long time may help them to sort of spend the time allocated for them, but that will not score more marks. The good student answer quickly. You don't have to sort of hurry, but sort of there should be a very rational flow. That is what you want to say, isn't it?
Yeah, it's rational, and sometimes they make us to prompt, and we ask why, how, why. I mean, make it, rather than make it a story and a eloquent way of speaking is very important. I think maybe they may not be able to do it in such a way, but still they have to learn, I think.
Yeah. The last student also, so when you asked sort of the fractures involves avascular necrosis, she was telling head of femur fracture and femoral head fracture. So probably the same thing they were repeating. So that repetition, if they can avoid that, that is good.
Good. Thank you.
Okay,
thank,
sir.
thank you, Ajit. Thank you,
Andu.
and thank you all students. And special thanks to Binto.
Good night, sir.
Good night.
Night.